This morning's general session will cover the evolving transplant landscape. There's quite a bit going on in the transplant arena, and that is an area that is of great interest to patients. And this morning, we're going to have several experts provide us insights from their perspective about what their organizations are involved in with respect to transplantation. Our first speaker is going to be Dr. John Snyder, who is the director of the Scientific Registry of Transplant Recipients. He is also the director of Transplant Epidemiology for the Hennepin Healthcare Research Institute. John is also a good friend. I've had the pleasure of serving on the SRTR for several years, as well as several other AAKP patients serving on important subcommittees that are involved in transplant-related activities. So let's hear from Dr. Snyder. John?
Hello, my name is John Snyder. I'm the Director of Transplant Epidemiology at the Hennepin Healthcare Research Institute in Minneapolis, Minnesota, and I have the privilege of serving as the Director of the Scientific Registry of Transplant Recipients, which I'm here to tell you some information about. I first want to begin by thanking the AAKP for the generous invitation to be with you today. I have gotten to know Mr. Knight over the years and consider him a friend, and really am thankful for the opportunity to talk with you all about the work of the Scientific Registry of Transplant Recipients and the fundamental direction we're taking to engage systematically the patient voice. And so my thanks to the AAKP for the opportunity to be with you today. Just a brief background, as I've mentioned, I serve as the Director of Transplant Epidemiology at Hennepin Healthcare Research Institute. We serve as the contractor with the federal government to operate the Scientific Registry of Transplant Recipients. And so I just note here that these views are expressed do not necessarily reflect those of the U.S. Department of Health and Human Services. I also have the privilege of serving on a few boards of directors in the field of organ transplantation. And so I just want to acknowledge the good work that's being done by Donate Life America and the Alliance for Organ Donation and Transplantation. I'm proud to serve on those boards. I also have the opportunity to serve on the clinical policy board of the organ procurement organization that serves Minnesota, North Dakota, and South Dakota, and that is LifeSource. By way of background, I'd just like to point out where the SRTR sits in the operation of the nation's transplant system. The U.S. Department of Health and Human Services has the division, the Health Resources and Services Administration, which has a division of transplantation that operates two major contracts in the field of solid organ transplantation for the United States. On the left, we have the Organ Procurement and Transplantation Network, which is operated by the United Network for Organ Sharing in Richmond, Virginia. And a sister contract to that is the SRTR, the Scientific Registry of Transplant Recipients, which is operated by my team at the Hennepin Healthcare Research Institute in Minneapolis, Minnesota. And the distinction I like to make between these two contracts, the OPTN UNOS system is, I would say, operates the nuts and bolts for the people in need of kidney transplants when they get put on a wait list. The OPTN manages that process, makes sure the donors are being matched correctly and organs are getting to where they need to be and transplanted into those recipients. The SRTR serves primarily a research function as well as a public reporting function. So we are charged with monitoring the status of solid organ transplantation in the United States and also consulting the policymaking bodies so that when they are considering changes to, for example, kidney allocation systems, our team may run a number of analyses for those committees to consider the data and hopefully make a correct decision in terms of how they're, or at least an informed decision in terms of how they're going to alter the policies to benefit patient outcomes. So the SRTR was established by the National Organ Transplant Act back in October of 1984. And this just gives you the public health law reference here. The Secretary shall, by grant or contract, develop and maintain a scientific registry of the recipients of organ transplants. And that registry shall include information respecting patients and transplant procedures as the Secretary deems necessary to an ongoing evaluation of the scientific and clinical status of organ transplantation. A lot of words, but essentially a scientific registry exists to help improve and monitor the nation's transplant system. So one of the main functions we serve is a public reporting function. We manage the website srtr.org, and you can see the reference there. And there's various performance metrics along with some other tools there that hopefully will provide useful information to patients in need of transplant. On the left here, I have an image of the United States. This is simply an image of some of the reports we have available at the portal into those reports for the 57 organ procurement organizations in the country. Those are the companies charged with working with deceased individuals to hopefully make their organs available for transplantation around the country. So those are designated by those colored regions on that map. So you can find reports about their performance and of those organ procurement organizations there. On the right, I have an image of one of the main pages of one of the transplant programs. In this case, I just picked out Ohio State University's transplant program, their kidney transplant program. And you can see just a highlight here of where that program is located, along with a couple key metrics that I can tell you a bit more about. One of the things we've worked on over the years is you will find if you peruse our reports that there are a number of very complex statistics in these reports. Assessing transplant program outcomes is a tricky business, right? So we have complex statistical models that we use to analyze outcomes and try to compare apples to apples across the different transplant programs. And so one of the things we're very proud of is we have, over the past 10 years, been really making a concerted effort to make the information more useful and understandable to patients. One of the ways we've done that is we've created these 5-tier systems that simply try to summarize a couple complex metrics into sort of, I think we're all familiar with looking at sort of 1 to 5 rating scales. And so in this example here, again, from Ohio State's program, we look at 3 main components of transplant program performance and rate them into these 5-tier systems so that patients can quickly get a good sense of how things are going at that program in the recent years. We look at survival on the wait list. So how well is are these programs patients staying alive while they're on the wait list in order to get organ offers? In the second one in the middle, how quickly is this program generally transplanting their patients? We know that all patients are unique and they have unique circumstances. And so we try to make adjustments in these models for the types of patients on their list and how acute they are. And so that is an overall assessment of all the patients on their list. Is this program transplanting them quickly or slowly? You can see this program here gets their patients transplanted quickly with a 5-bar rating in that as well. And then we look at outcomes. The summary here is first-year kidney survival after your transplant. So are you alive with a functioning transplant 1 year after the transplant? We know from talking with patients that 1 year is absolutely nice, but patients would also like to know longer-term outcomes. Now, within the reports, if you click through into more detailed data, we do have a 3-year outcome available, and we are currently working on a 5-year outcome as well. So hopefully stay tuned and you will see that 5-year outcome presented in the future. You'll find we've tried to produce some simple, engaging graphics in these reports. Here's a simple summary of the inflow and outflow of the Ohio State University Kidney Program's waiting list. And so you can see starting with 516 people in July of 2019, and then we go through a year period, and now they have 530 on their list. You can see the reasons that patients are removed from their list as well. And these reports update every 6 months. And so you'll see every 6 months in January and July, these data will update and show you the most recent 12-month period that we have available. We have simple summaries of how quickly patients are being transplanted at this program. Here you can move the slider at the top from 30 days to 1 year, 2 years, 3 years, and the data will change to show you at this program what proportion of their wait list is transplanted by that time. So here we're seeing that at this program, 22% of the patients on the list have been transplanted by 1 year after listing, and that compares with nationally at the right 16%. So slightly higher than the national experience here, and this is what that gives this program that 5-tier rating for getting patients transplanted faster. This is a bit more complex, but I wanted the patients to be aware that we do have data in the reports that look at this program's proclivity to accept organ offers. We do know that some transplant programs are more aggressive in the types of donors they will use, and that may be reflected in when they receive offers for programs. Are they more or less likely than their peers to accept those offers? We do that by presenting what we call an offer acceptance ratio. And something right around 1.0 would mean that they are accepting offers right at the rate that we would expect them to accept them. In other words, they're doing just like the peers would nationally. If a program has a higher than expected offer acceptance ratio, you would see a number higher than 1. Say a 2 would mean that they're twice as likely to accept organ offers than other programs for similar candidates and similar donors. Or something like 0.5 would mean that they're half as likely to accept those offers. And so you can find data here for all offers. You can find data for certain hard to place types of donors. Is this program aggressive in accepting those? Often we see that programs that are more aggressive with their acceptance practices can get their patients transplanted faster. So we hope that these are useful data for the patients. So how are we systematically trying to engage the patient voice? The SRTR has an oversight committee that we would call our SRTR review committee. And just this year, we worked with HRSA to establish 3 subcommittees, one being the Patient and Family Affairs Subcommittee, and then we have what we call a Human-Centered Design Subcommittee, and finally an Analytic Methods Subcommittee. So the top 2 there, I think, are of most relevance to the patients themselves. The Patient and Family Affairs Subcommittee is advising the SRTR on issues of most importance to the patients and families that the transplant system serves. We're trying to systematically hear their recommendations in their voice. The Human-Centered Design Subcommittee then takes those recommendations and helps the SRTR design effective websites, effective reports. If our data are too complex for patients to understand, we know that they would not be useful. And so we're trying our best to take steps toward systematically developing reports that the patients will tell us are really helpful and useful to them. So we're thrilled to have those 2 committees that work together. The Analytic Methods Subcommittee is made up mostly of PhD level statisticians that can make sure that we're getting the methods correct behind all of this as well. Here's just a listing of our current Patient and Family Affairs Subcommittee. I won't go through the names. I will point out that we're fortunate to have Richard Knight as our co-chair of this committee, obviously current president of the AAKP. And so we're really blessed to have Richard's insights helping us here. Here's an image just for some of the work that the Human-Centered Design Subcommittee is helping us with. The image here is from a tool that's being developed by Dr. Corey Schaffhausen, who is our SRTR Human-Centered Design engineer. And this tool is part of a larger project that would help patients better understand the offer process when they're receiving offers for their organ. We want to make sure patients are prepared and ready to receive those offers and understand the relevant issues related to those offers. Just want to make the group aware that the SRTR also this year is embarking on a new initiative that we affectionately call Task 5. And that simply is a reference to our contract with HRSA. HRSA has asked us to engage in a process to identify metrics to assess national transplantation system performance and support informed decision-making by critical audiences. Obviously, the patient voice is a critical audience in terms of data that the SRTR can provide. So we're thrilled to have this new task that will really be underway for the next 5-year period to systematically identify these metrics. We're going to do that in a number of ways that I'll show you on the next slide. So here we see the process for Task 5, just highlighting on the left. It's a 5-year project. We are in year 1 currently. We have formed a steering committee. We are going to host a consensus conference as part of phase 2 that would take place approximately a year from now in the summer of 2022, where we hope to bring together many stakeholders in the transplant system and the data provided by the SRTR. We will hear recommendations. We will then spend the next phase implementing those recommendations and then systematically evaluating that change. On the right, the wheel is meant to represent that this is going to be an ongoing process going forward. We're hoping to systematically, about every 3 years, roll through a process of hearing from the community, making changes, evaluating those changes, and then hearing from the community again. So we will be looking for ways to engage the patient voice throughout this process going forward. We will be conducting patient focus groups as we lead up to the consensus conference. We have Dr. Allison Hart on our team. She is the senior staff for patient and family affairs, and she will be convening a number of patient focus groups. We hope to get broad representation from lots of different patients, genders, racial, ethnic makeup, geographic diversity as well. I'll have some contact information at the end of the presentation if that interests you to participate in those. So where can you stay informed? There's a lot of information. I encourage you to peruse the SRTR's website. If you have questions, the best way to contact us is emailing us at srtr@srtr.org, which is you can find at the bottom of the screen here. We have a newsletter. You can find the sign up for that there, srtr.org/#newsletter, and you can sign up for that. We have a Twitter feed, we have a LinkedIn, and we have a YouTube channel. You can find numerous webinars on our YouTube channel for helping patients navigate our data and website. And so we hope all these resources are available and useful to you. Encourage you to contact us at any time if you have questions about the data. And again, I thank the AAKP for the invitation to be with you today, and I look forward to meeting a number of you in the future as we engage the patient voice more directly. Thank you.
Thank you, Dr. Snyder. We appreciate your insights, and more importantly, we appreciate everything that you're doing for patients. Now, ladies and gentlemen, we're going to hear from Dr. Lloyd Ratner. Dr. Lloyd Ratner, a good friend of the American Association of Kidney Patients and a frequent guest who has provided information in webinars and has always been available to answer questions that we may have. Dr. Ratner is the Director of Renal and Pancreatic Transplantation, Department of Surgery at Columbia University Medical Center. He's the immediate past president of the American Society of Transplant Surgeons. And he is going to provide us information from a transplant professional perspective. Dr. Ratner?
Hi, my name's Lloyd Ratner, and I am a professor of surgery at Columbia University in the city of New York, and I am the director of the Renal and Pancreatic Transplantation program here. The AAKP has asked me to talk today about strategies to decrease kidney discards, which I'm happy to do. Unfortunately, I don't have any relevant financial disclosures. I do have a fiduciary disclosure in that I am the immediate past president of the American Society of Transplant Surgeons. However, all the opinions expressed in this presentation are strictly my own and don't represent those of any other organization, including the American Society of Transplant Surgeons. I'm going to talk about a number of strategies to reduce the kidney discard rate. And these are to reduce risk aversion, to improve allocation efficiency, to improve provider and patient education, to have a more realistic assessment of donor quality, and to provide a safety net for patients with suboptimal outcomes. And then I'm also going to tell some suggestions for policy strategies, which I think would help in these regards. So it's important to understand that there is a complex transplant ecosystem consisting of referring physicians and dialysis providers, donor hospitals, organ procurement organizations, transplant centers, payers, the organ procurement and transplant network and the allocation scheme, and regulatory agencies. And these interact, as you're going to see, and have an impact on whether or not we utilize or discard kidneys for transplantation. Now, as you're probably aware, the number of kidneys that are being procured and are being discarded from deceased donors has increased over the last decade, or the last 2 decades. And now we're at about 20% or greater of the kidneys that are procured from deceased donors are being discarded. It's important to understand how the allocation system works in order to understand why kidneys are discarded. Now, the allocation system uses a construct called the Kidney Donor Profile Index, which basically what this is, it tells us a percentile ranking of the quality of the kidney in terms of its expected graft survival, so the kidney survival over 1 and 2 year period. And it uses a multivariate analysis, and you can see the variables that go into this multivariate analysis. But what's important to know is that there's a percentile ranking that gives you the quality of the kidney. The higher the percentile ranking, the worse the quality of the kidney, the worse the expected outcomes. It turns out that a very large percentage of these kidneys that are discarded are the high KDPI these high KDPI kidneys. And you could read the caption there. It says, "I've got good news and bad news. We found a donor, but the guy was 104 years old." Well, obviously that's not going to be optimal. If we look at the discards by KDPI, which is the percentile ranking, the absolute numerical value given to kidneys is what's called the KDRI, but let's stick our discussion to the KDPI. So if we look at a KDPI of 85% or greater, about half of those kidneys that are procured from donors that fall into that KDPI range are discarded. Okay, 50% of those kidneys are discarded, which is a huge amount. If we're going to increase the number of organs available, the large increase is most likely to come from the organs at the margin or from the donors at the margin. Now, if you look at the graph on the left, and there's a table within that graph, you can see, though, although 50% of high KDPI kidneys are discarded, 50% of the discarded kidneys are from donors that have KDPIs less than 85% or greater. So what would seem like good kidneys are being discarded as well. This is a picture. You can see a gentleman, that's Sumit Mohan. He's one of my colleagues at Columbia University. And we published this finding that the discard of kidneys varies by day of the week. And those with the discards being greater on the weekend, and the kidneys that are discarded on the weekend tend to be of better quality than those kidneys that are discarded on weekdays. Okay? It's like there are more bad kidneys on the weekends. The discard rate goes up, meaning we have to discard kidneys that are of better quality. Now, that implies that it's not just the quality of the kidney that is factoring into why these kidneys are being discarded, but rather organizational and operational factors at the level of the transplant center that impact whether or not kidneys will be discarded or not. Dr. Mohan and our group went on to publish another paper which also shows that there is huge geographic variability in the chance of getting a kidney and utilization of organs. And this graph shows broken down into the 11 UNOS regions. But you could see the vertical bars also show the variability between centers within a given region. And you could see there's very wide variability from one center to the next, whether someone will get transplanted, and correspondingly, whether or not they'll utilize organs and whether or not those organs will be discarded. So again, there's a systemic problem here. So let's start with the first issue, and that's that of risk aversion. Well, currently, the regulatory environment that looks at transplant center performance looks at outcome measures, and they focus on 1 year patient and graft survival. Important in that is that there's an imperfect risk adjustment. So we get compared to the national average. They try to risk adjust based on the quality of the donor and how sick the recipient is. But the risk adjustment is a little bit better than a coin toss. The problem is further compounded by the fact that it's a punitive system. So if you get flagged as being performing less than expected, you get punished or can be punished. and there's no incentives to utilize suboptimal kidneys. There's an imperfect risk adjustment, so it doesn't, all the factors that go into why a kidney is not optimal to use doesn't go into the outcomes measures, and so you could only get hurt if you go out on a limb and use a suboptimal kidney from the standpoint of the transplant center. Now, there are also financial risk aversions. Recipients of these suboptimal kidneys are generally harder to take care of and tend to be more expensive. They have longer length of stay in the hospital. Many of them, and I'll show you some data about this, need for post-operative dialysis, which is more expensive. And yet there's no differential payment for whether or not you're going to use a suboptimal kidney versus an optimal kidney. And so centers with narrow margins are disincentivized to utilize these suboptimal kidneys, which then leads to their discard. There are a number of things which will impact a center's risk tolerance and or aversion. Things like the risk of primary non-function or delayed graft function. Primary non-function is when the kidney never works. Delayed graft function is when the patients require dialysis after the transplant until the kidney recovers. Whether or not they ever get to optimal function or whether they just kind of sputter along suboptimally and only give, sort of partial function to the recipient. Whether or not they're expecting to have a shorter graft survival. If they've been injured in some way and are likely to bleed, which make it more difficult to manage the patient. If they're at risk for ureteral or vascular complications, or if they're at risk for transmitting diseases like HIV, hepatitis C, parasitic diseases, cancers, et cetera, et cetera. So all of these things factor into why centers may have risk-averse behavior with some kidneys. This is a very famous graph. This was published by Jesse Schold from the Cleveland Clinic, who basically looked at centers and looked at their outcomes. And the top line, line number 1, shows the patient survival in those centers that consistently perform better than expected. The second line is the patient survival in those centers that consistently performed as expected. And the third line is the patient survival in those centers that consistently performed less than expected in terms of their outcomes. Okay, those centers that are likely to be flagged for suboptimal performance. But when you compare that to the fourth line, which is those patients who are transplant candidates on the waiting list who don't get transplanted and remain on dialysis, you can see the patient survival is hugely better, even in the worst performing transplant centers. Well, why is that so important? Well, because again, those centers fall into a punitive system. And Schold then went on to further show that anytime a center gets flagged for having suboptimal or low performance under expected, then in general, their volume of transplants decreases by about 30%. So making it more likely that they'll discard organs and making it more likely that they won't take on difficult patients. Let's talk a little bit about allocation efficiency. Well, the allocation algorithm is complex, but to a large extent, it's driven by waiting time. People with long waiting times are unlikely to accept suboptimal kidneys. So for instance, I call up Mrs. Jones and I say, Mrs. Jones, we have a kidney for you. We have a wonderful kidney for you. You've been waiting 8 years. And she says, oh, Dr. Ratner, I'm so excited. But is this a good kidney? And I said, well, yes, this is a very good kidney, but 90% of kidneys are better than it because it's a 90% KDPI. Who would wait for 8 years and then accept that kidney when maybe 2 weeks or a month later, they'll get a much better donor kidney? Okay, so then we go to the next person on the list, same discussion, on and on down the list, okay? And as that goes on, as we keep offering the kidney to more and more patients, the amount of time it takes, the clock is ticking. So the longer the kidney is outside of a living human being, the greater the chance it won't function appropriately. So these long allocation times make suboptimal kidneys even more suboptimal. Then you get to the point where you have transportation logistics, and these are problematic. And so if you can't allocate it to someone locally and you need to make a broader net to send to and try and get it allocated nationally, well, the kidneys fly on commercial airlines. And, so if there are no flights available because now you've spent the last 6 hours trying to allocate the kidney and now it's 8 o'clock at night and there are no flights until the next morning, you've just added an additional 12 or 14 or 15 hours onto the kidney. These long allocation times are often compounded by lack of flights and long logistical delays. Now, my point here is that, these wind up, because we're talking about trying to have equity, and, those patients who have waited the longest should get the first shot at the kidneys. Well, my point is that if these kidneys aren't going to be utilized, there's no utility. Without utility, then equity is moot. So we should have a much more efficient allocation system, which could get these kidneys to people that would actually use them. Well, let's talk about these hard-to-place kidneys. Well, this is a paper from a paper that my group has recently submitted that looked at hard-to-place kidneys. Now, UNOS defines hard-to-place kidneys as those where you go down to the 100th person on the list or greater to get this kidney accepted. Okay, so we looked at those kidneys that were transplanted into patients 1 through 7 on the list, 8 through 100, and then we looked at the hard-to-place 101 to 1,000, and then we looked at these super hard-to-place where we went down greater than 1,000 patients on the waiting list. And if you look at the highlighted yellow areas, the first area that you see is the cold ischemic time. So you could see that the hard-to-place kidneys, 100 or greater, have about 10 more hours of ischemic time outside of a living human being, than those sort of optimally placed kidneys. And if you go to the super hard-to-place kidneys, they're about 15 hours for the other ones and 18 hours for the super hard-to-place kidneys. So we're sort of hurting these suboptimal kidneys even more. And that's reflected in the outcome. So if you look at the bottom yellow boxes, the PNF stands for primary non-function. Those are kidneys that never work. It's about a 3-fold difference between these hard-to-place kidneys that are more likely to be discarded, and the delayed graft function, in other words, needing dialysis following transplant, is about twice as much. So again, making it more difficult to place these kidneys with suboptimal outcomes, although these outcomes are still very, very good. But in our current punitive system, there's risk aversion because of that. Overall, these generally tend to do well, and you could see that although there is a statistically significant difference in terms of the outcomes for the hard-to-place kidneys, which are the lower 2 lines, versus the upper 2 lines, which are the easier-to-place kidneys, the outcomes are still quite acceptable and way, 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 way better than on dialysis. So let's talk about provider and patient education. Well, there's that of organ acceptance. Well, I think, like I tried to explain to you with the issue of the KDPI, the consent and allocation process are pejorative to the kidneys. We have to disclose all these facts about the donors, whether they were at risk for contracting other illnesses and things like that. Kidneys for transplantation are sort of like used cars. You can never get a brand new one right from the factory. Some will have more mileage than others. Some have been maintained better than others, but you're never going to get a perfect one. I think another misunderstanding is that the degree of HLA matching is really of limited significance, and the risk of disease transmission is really extraordinarily low, even in those people who have social behaviors which would make them seem like they're at risk for developing diseases like HIV, hepatitis C, etc. What we really need, and we have some, are prognostic tools that tell us, number one, what's the chance of dying on the waiting list? What's the likelihood of getting a better kidney offer? How long will it take to get a better kidney than the offer currently at hand? And how can these tools realistically be incorporated into the real world situation? Because when I get a kidney offer at 3 in the morning and I may be operating, there's no way we could go and look into these calculators, and it's unlikely that the patients will utilize them either, and we have very limited time to make decisions about this. So we need more realistic utilization of tools like this. So let's talk about a safety net for patients with suboptimal outcomes. Well, if a kidney fails early on, the patient will get their waiting time back. But there are no accommodations for kidneys that never function well but kind of continue to sputter along. So, if we look at glomerular filtration rate, maybe someone will get a kidney where the glomerular filtration rate is only about 22 or 23%. It may keep them off dialysis, but that's not much better than an end-stage kidney. So there's no real incentive for patients to accept a kidney like that. Patients should be prioritized if they accept a suboptimal kidney that either fails early on or functions poorly. There is a precedent in terms of the safety net for liver transplant recipients who have kidney disease who may also be candidates for a kidney. But now, if they just get the liver transplant, they are prioritized to get a kidney later on if it turns out that they really need a kidney transplant. I think we also need a more realistic assessment of donor quality. I talked a little bit about the risk adjustment. Well, things like high KDPI, donors at extremes of age, elevated creatinine versus acute kidney injury, or long ischemic times, those go into the risk adjustment. But things that don't include comorbid conditions, pathologic features when you look at the kidney on a biopsy. If you put them on a perfusion pump, we could use those pump parameters, the flow rates and resistance within the pump as prognostic factors, the risk of disease transmission, and whether or not the kidneys, what I call, are anatomically incorrect. Do they have any procurement injuries or injuries from the cause of death, like a motor vehicle accident, tumors, whether they have anomalies, congenital anomalies, and whether they have multiple vessels. None of that goes into the risk adjustment or the assessment of donor quality, but they do go into our assessment of whether we use them or not. Well, here's my favorite philosopher, Yogi Berra. He said, if people don't want to come out to the ballpark, how are you going to stop them? That was in the time when television first came out and people were watching TV rather than going to the ballpark. So the Ratner corollary is, if people don't want to transplant kidneys, how are you going to stop them? Well, I think we need to change performance metrics to assess the entire continuum of care with an intent to treat analysis that looks at evaluation, listing, pre-transplant, transplant, and post-transplant, and that'll encourage people to utilize more kidneys. What I call dealing from the bottom of the deck, and that's that if we give these suboptimal kidneys to the patients with short waiting times rather than the patients with long waiting times, this will mitigate the suboptimal outcomes of these high KDPI kidneys. It's difficult to do this with our current allocation system, and with these kidneys, recipient selection is critical. So the idea is to give these suboptimal kidneys to the patients with the shortest waiting times who are unlikely to survive to get to the point where they'll be getting better offers. And then finally, what I call the wildcard solution. And this is to encourage listing of patients. We would say that a percentage of those patients who get listed can receive the wildcard designation, maybe 5%. So a wildcard designation will exclude patients from the overall performance metrics. But you would have to designate this wildcard prospectively before transplant. So what that would do is would encourage transplant centers to transplant patients with risks not included in the risk adjustment, but also to be able to utilize kidneys that are not accounted for in the risk adjustment. You just declare it prospectively and say, okay, I'm going to transplant this kidney into this patient, and they're going to be a wild card patient, be removed from the the performance metric. It would also encourage cohorting of patients with difficult problems, and it would encourage innovation and experimentation. So I think that's a good way to solve a bunch of problems. So in summary, there are a number of interrelated factors that lead to kidney discards. Current policy does not discourage the discard of kidneys. Risk aversion and allocation inefficiency play important roles in organ discard. Reduction of kidney discards will likely result in suboptimal outcomes, but those suboptimal outcomes will be better than the alternative of not being transplanted. And there are a number of policy approaches to addressing this problem. So I'd like to thank the AAKP for allowing me the opportunity to address you today, and I wish you all good luck.
Thank you, Dr. Ratner. Thank you for that very insightful presentation. Thank you for all that you do for patients. Now we're going to hear from Ms. Jan Finn. Ms. Finn is president of the Association of Organ Procurement Organizations. She is also CEO of the Midwest Transplant Network. The OPOs play a very, very important role in transplantation. So we're looking forward to hearing her insights about the role that her organization plays and what is it that OPOs do that we need to be aware of. Ms. Finn?
Thank you so much for having me here today. My name is Jan Finn. I represent the Association of Organ Procurement Organizations and currently serve as their president. I'm also honored to be the president and CEO for the Midwest Transplant Network in Kansas City. So today I want to share with you a little bit about what AOPO has been doing and how we're engaging with stakeholders to improve the lives of all of those patients who are waiting for a transplant, and also the donor family situation when we are there to impact their lives in a very different way, but to continue the legacy that we are creating with saving more lives. In keeping with the collaborative theme, the questions to run on, I always like to do questions to run on, and I will answer those over the next few minutes with you. The importance of the AOPO goal. We are mission focused in all areas of donation and transplantation to save lives as healthcare providers. And we are building a system to support our mission, those missions of every OPO and every hospital and transplant center serving the communities. It's imperative that we continue to work together as a donation and transplantation system to fully develop a more collaborative system to address mechanisms which will promote quality improvement and lead to saving additional lives. Your role here today is as a committed stakeholder, and we hope that sharing these ideas with you, you'll be able to say how you could possibly be a part of saving more lives by contacting your local OPO or one of us to let us know how you could be more involved. I want to give you an example of that. I recently spoke to one of my nursing school colleagues from many years ago. Her daughter-in-law was about to be an organ donor. And last month, her entire family was so grateful for the opportunity to give others a chance. Her life-saving act was possible because of collaboration between donation and transplantation. You see, in this situation, she was COVID positive. And we learned from others that those organs too can be transplanted by reaching out beyond our normal circles, and in this case, to the Cleveland Clinic. She was able to save two lives, making a difference for 2 kidney patients that received her organs. So that's why we believe this is so important to engage with stakeholders and continue this important work. So I share with you a picture of the donation service areas across the country. We have 57 OPOs or DSAs across the country, and we all work together in this mission work. The AOPO represents 48 of the members, yet we continue to collaborate with all transplant centers and donor hospitals across these communities and work together to raise awareness in increasing the number of donors by registering as first person or actively working in the communities to engage in activities that raise awareness, and along with hospital staff, donors, donor families, all making lives better with transplantation. Just to share with you a little bit about AOPO, you may know who we are, and I want you to know we've recently revamped our mission and our vision. So we are leading the nation's organ donation community to save more lives, as I've just mentioned. Our vision is to pursue the day when every donation opportunity results in lives changed. So the US system has been incredibly successful and most recently was able to surpass Spain in the number of organ donors per million population. Quite a feat when you think about this great growth that we've had and also being able to be the leader in organ donation in the world. So it's a celebratory moment for us. That doesn't come easily. It comes through much hard work. And as I'll show in the next slide, organ transplantation from donation after circulatory death is one of those examples. It has been embraced by the donation community, and as you can see with this graph, grown to great heights. We continue to expand with these types of donors. Traditionally, donors are able to provide organs for transplantation through brain death criteria. Not every patient meets that criteria, but they are able to donate after circulatory death. And in these situations, we are still able to transplant organs. And so these 3,224 donors in 2020 are incredibly important in the role of increasing the number of transplants. So you might be wondering, what's the current state in 2021? As you know, COVID has impacted all of us. It has put a great strain on our hospitals, the healthcare workers, yet they remain committed to working with us as OPOs. U.S. organ donors are 8% higher as of May this year, growth over 2020, and about 50% of the organ procurement organizations are on track to increase the donors again. And half of those being at 10% or greater is such a great sign for us. We know that this goes through much work in all of the organ procurement organizations. We're excited that earlier this year, we were able to launch our goal to save more lives with the 50,000 organ transplant goal by 2026. Definitely this will be a record for us. We wanted to have a positive focus for all OPOs, including how we can get there through improvements that are already underway, such as we talked about with DCD. And we know it's an exciting time to consider possibilities and how we can continue to make a difference. But we need you. We need you as our stakeholders on this journey. The success of the donation system over the past 10 years has consistently grown in the number of transplants, and that's really remarkable. It is higher in 2020, as you just learned, which is great news for waiting recipients. We acknowledge that there's variation in performance across all OPOs. So AOPO is committed to learning what does work, what are the known best practices, and to share those broadly with others so that the performance can be improved for everyone as we move towards our 2026 goal of 50,000 transplants. It will take a concerted effort from all stakeholders to make this work. So our key initiatives, collaboration across stakeholders. AAKP, those of you involved as kidney patients, waiting recipients, and transplant patients are key to our success. We are collaborating across the donation and transplantation organizations, and this is how we will reform the system. We believe in putting a bold aim in place takes a lot of guts, let's just say, but it provides us a sense of direction and support. When we know the aim, we also know that there are improvements along the way. We need a system in place to make sure that we are able to put the interventions in place, to work with stakeholders, and just know that the day when every donation opportunity results in lives saved, we are moving closer to our vision. Much of the work today in the world is centered on the equity issues, so DEI is really important and certainly a focus for us. We want to reduce disparities, especially in transplantation. We know that Blacks are 3 times more likely to need a kidney transplant. Native Americans are 4 times more likely. And Asian Americans are 4 times more likely to develop hepatocellular cancer, one of the key indicators for liver transplantation. The median days is definitely longer for these groups in the time that they're waiting for organs. So what we want to do is to make sure in our efforts that we dispel any myths that OPOs are implicitly biased, that there are any situations where we do not respond to potential donors, or our response times are flawed, our interactions and engagement are not up to par. We stand ready to demonstrate how we perform to save lives and engage with others in a transparent manner. AOPO must be the part of education on all of these issues and training to improve processes. Every AOPO member and OPO is asked to perform a DEI assessment on their own organizations to position themselves to learn how to close gaps, and we want to provide resources to each of the OPOs in order to make sure that we are addressing the health equity issues. So who are our stakeholders? I love this picture because it really means that we are engaging with so many wonderful people out there. Some of those key stakeholders are listed here. So AAKP, serving kidney patients across the education avenues, the advocacy avenues, since 1969 is the independent voice for kidney patients. You are helping those patients live better and live longer. And you can see there are many associations here that we work with on a regular basis, whether they be patient advocacy groups, transplant hospitals, the American Hospital Association, certainly CMS and the end-stage renal disease networks across the country. We also work very closely with donor families to learn from them how we can do better for all recipients. And it's always what we are doing to work towards reducing the number of people on the waiting list. As we know currently that kidney transplants not only save lives, they extend lives, they make possible many memories that would not be possible without a better life or better chance with a transplant. So we intend to expand our collaboration. And by this, I mean that we want to learn from others. It's often said, you don't know what you don't know. And in AOPO, partnering, as I mentioned earlier, with all of the associations, professional societies, we can learn the advocacy efforts that they are working on, coordination of activities, or discussing joint ventures. The Kidney Collaborative is one of those joint initiatives. We will be building on what has happened previously with collaboratives. Many of you may remember the HRSA collaboratives from before, and we were able to make great strides in increasing the number of organs for transplantation. With this kidney collaborative, we will also be working on decreasing the number of unused donated kidneys. So several OPOs recently published a paper that I might want to call your attention to, the Wyman Report, and there were many outlined initiatives there to help decrease kidney discards in particular. Those are the types of things that we talk about in collaboration with other OPOs so that we can put these on the table for example, maybe a PDSA or a trial to see what would this do to help increase the number of kidneys. We want to get to 28,310 kidney transplants in 2026, which is a 61% increase from where we were in 2020. That will take continued growth. It will take continued progress, as we've talked about with DCD, but some of the other initiatives I want to share with you. One of those being data sharing. As I mentioned best practices earlier, OPOs learn from each other. We learn from testing strategies and examining the data, and learning is really vital. So AOPO is committed to data gathering on key elements and sharing those broadly in a manner which possibly would be de-identified to protect the OPOs. However, we want to do it in full swing together, and we have a data definitions task force that is ready to move forward. We operate in an all teach, all learn environment, and the OPOs are accustomed to reaching out to others to see what they are doing and to implement similar things. Such things that have been implemented in the past are DCD donation programs. That really started during the first collaborative. We also want to learn from transplant centers. What are they doing so that they are getting more patients transplanted? When we have data, not only on OPOs, but on transplant centers, we're able to reach out and learn from them and be able to utilize those things to move forward to save more lives. So let's talk a little bit about some of these key strategies. We want to increase donation authorization, increasing donation in multicultural communities, obviously encouraging donor designation through first-person registries, enhancing the family donation discussions, and definitely facilitating first-person authorization. Across the country, we've experienced as OPOs some opposition to first-person authorized donation. It is our responsibility as OPOs to work collaboratively with the hospitals, to share with them how this can work, and definitely to honor the gifts that were designated by the person. So those are just a couple of ideas and strategies that we will be working on and currently are to improve in all these areas. So advocacy is something that I think is really important in the work that we're doing. It is one of our pillars to continue to educate our elected officials. And it's not really about trying to change anything or to advocate against something. It's really to provide education, and specifically on things that we believe are important, our donation message, promotion of donation. And we know that some of the effective communication that needs to happen happens through repeated messages. So often we're telling the same types of stories. We are offering a message of hope and for our life-saving work. The dedication from all of us in donation and transplantation is to improve opportunities for recipients to create legacies. So we listen to elected officials. We also are educating them in the process, but it's about this positive focus on the success of the system and to explore new opportunities. So in continuing to think about advocacy, I mentioned earlier that we want to talk more about known best practices. I mentioned some of those things with our DEI initiatives and also fairness in donation and the allocation of organs across the country. But one of the things that AOPO can definitely help with is to advocate to OPOs for what is best. Some OPOs, as I will tell you, the country is very different. You saw on the slide earlier, some serve smaller areas and may have limited resources, but together through AOPO, we are advocating in how we can better serve more diverse populations. We can ask those types of populations to share their experience and how we can integrate across all the underserved. It also means advocating across various social media platforms to share our educational messages, but also more about how donation and transplantation really works. So a couple of other things just to mention. In terms of accountability, we are focused on how to work within the system to utilize more of the recovered organs. I mentioned earlier that this is definitely a challenge when we're talking about utilization of organs from older donors, DCD donors, or more complex donors. We need to work more collaboratively with smaller transplant programs and large programs to understand how we can ensure that these organs that they are selecting is the right organ for the right recipient. We are working through these complex situations on a daily basis in the organ procurement organizations. So we are constantly learning and implementing new things. One thing that is of importance, I mentioned earlier about COVID positive donors. Prior to 2020, that wasn't even a question, but now we've learned ways that those organs can be successfully transplanted. The same is true for hepatitis C positive organs. When we talk about challenging cases, more complex areas, and even the acceptance of DCD organs, we know that we will learn the most from those that are doing that work. So studying the best practices of transplant centers. If you have anything to share with that, an innovative practice or initiative that you've been involved in, shoot me an email because we want to learn from you, from our transplant partners, and certainly other OPO partners and how to partner together for better performance. One such example that I can tell you about in recent years with innovation, I think is really important to consider organ perfusion. Transplant programs are successfully using DCD hearts with the aid of machine preservation. There's an OPO in San Diego that has coordinated 10 such donations this year. And that means 10 people received a heart transplant that previous to this innovation would not been able to do that. I mentioned earlier the COVID positive donors that we've had here in the Midwest. We would not be able to do that without a transplant partner in Cleveland to be able to say these organs will work. So while technology may drive many new therapies, it is also an innovative spirit and collaboration to consider how organs can be utilized. This work really goes hand in hand with all the things we're doing when we talk about advocating to inform elected officials about the good things that are happening. One of those would be partnering with hospitals for electronic referrals so that we can streamline the process to allow earlier intervention on particular donor cases and to support the donor hospitals and families, all in an effort to save more lives. All of these things are working comfortably together, and many areas that we know we will continue to expand upon throughout the coming years, and definitely moving towards 2026 when we get to our 50,000 goal. 50,000 lives saved by transplantation is an incredible way for us to focus. Thank you so much today. I really appreciate you being a part of this, and I hope that you're excited about what AOPO is doing. Certainly, you know that we have great initiatives in process, and it's all focused on saving more lives. So we hope that you'll go along this journey with us. We need you, and certainly you have my contact information in case you need me. So go out and do something great today, and let's make more lives happen through donation and transplantation.
Dr. Snyder, Dr. Ratner, Ms. Finn, we appreciate the opportunities and the insights that you have provided us with respect to what's going on in the transplantation arena. And we will certainly use this information again to educate our patients so that they are in a better position to pursue a transplant. Thank you very much. Have a great day.